performing intubation. Jeremy thankfully agreed to volunteer because we will need a patient, and so he stepped up and thank you for that.
Way to take one for the team.
Take one for the team, exactly. No, we'll have our intubation heads, our intubation mannequins there in the lab that we'll practice with. But anyways, without further ado, let's kind of get rolling here. All right, so different ways to establish an artificial airway. Now, this is an airway that's beyond just the pharyngeal airways. Pharyngeal airways that only go into the pharynx, the NPA, the OPA that we talked about last week. This is a true tracheal airway, an airway that will eventually end up in the trachea after proper placement. Three primary ways we'll discuss here: an orotracheal intubation. Not trying to sound fancy or anything like that, but that's what sometimes the MDRC, how they'll refer to intubation, that breathing tube being placed in the airway. They'll call it orotracheal. Again, it's an orally inserted endotracheal tube into the trachea. That is the preferred method. Most patients who do have to be intubated, that's the primary route of intubation, is an orotracheal intubation. Reason being, it's probably the easiest and quickest way to intubate a patient, the orotracheal route. Nasotracheal intubation, same tube. Instead of being placed orally, it's being placed nasally. We'll go over reasons for that, but there are certain clinical situations where that is absolutely necessary. You couldn't do the orotracheal route. So nasotracheal is not the preferred method, but sometimes you will encounter situations where the patient is intubated that way. And then the last one, a tracheotomy. We'll talk about that some more today, kind of toward the end of this lecture, about placing a smaller but equally effective airway directly into the trachea through a surgical incision there in the neck. All right, let's talk about the equipment. The whole laundry list of equipment that's necessary for intubation. This is from page 755 of the textbook. I just stole what was listed in box 37.3 about all of the equipment that is necessary. Now, I'm not going to explain what each one is because we'll kind of go through that with this lecture, but the list is plentiful, and everything has a purpose. Sometimes I might not use everything on this list, but I do need to have access to it because, again, remember, when these airways are placed, usually it's because it's an emergency, and we don't have a lot of time to think about it or go hunt something down. This stuff should be readily available to us. I will say this, sometimes in clinicals, I know some of the hospitals will put students together and say, hey, we need some intubation kits set up. Have at it. Everything you need is in the supply room. Go put some kits together for us. You may think, oh, that's really mundane. I need one of these, I need one of these, I need to add 2 of these. It's super important, because what if you forgot something that could be vitally important during the process of intubation? So like I said, I'm not going to go over every single one of these because I know we're going to talk about almost every one that's here. I will kind of jump down PPE, the personal protective equipment that we would need to be wearing, but I think the other stuff we will mention at some point or another today. Or, for example, Yankauer suction. Well, I know we won't necessarily talk about that today, but we talked about that last week. Again, for oral intubation, maybe you just need to clean out the mouth from a lot of oral secretions that have built up. But let me go on. All right, so still part of the assembling and checking the equipment. Number 1, you will need a laryngoscope and a bulb, blade, and a laryngoscope blade. That is going to allow us to be able to move the tongue out of the way so I can see. Notice it also has a bulb on the end of it that is providing light. If the bulb didn't work, there's no way I can do this because I won't be able to see anything. It's too dark down there in the airway in the back of the throat. So handle, blade, now bulb of course on the end, but inside that handle typically it's going to have some batteries. And do you ever think the batteries do expire, they do die? So you put things together, you open it up, the light doesn't turn on. Maybe it just simply needs a new set of batteries. Typically, depending on the size, something like this size would require 2 C batteries, which we have absorbent amount of batteries available to us to replace. Now also, depending on the style of laryngoscope blade and handle, sometimes this bulb is literally like a light bulb you would screw into an outlet. Sometimes you simply have to replace the bulb if the bulb burns out. Some of them have a bulb that's permanently attached that you would not be able to remove. In that case, I would just get rid of that blade and replace it with another blade. So it really just depends on the equipment your hospital has available to you. Now, step number 2, we talked about last week what an endotracheal tube is.
Just a quick question.
Sure.
Are those, like you said, you would just replace if the bulb was out, but do they have those where those are all like completely replaceable at any time? Like if they were, how in the last class, you know, we have these, you can either buy them to clean them or you can buy them for one-time use.
Okay, so there are some that are disposable. Yes, absolutely. There are some that are disposable. There's also some that are not. They're going to be reused.
Yeah.
So they have to be processed after the intubation procedure.
Just
So yeah, some of them are disposable. I'm glad you asked that. All right, so we did talk about what an endotracheal tube is. We talked about that pilot line connecting to that cuff that we add air to, and that cuff inflates, remember? What if I open this endotracheal tube fresh from the package, it's brand new, it's never been opened before. Am I gonna assume that cuff will properly inflate? No, I never can assume it will properly inflate. So that's what we're doing here, testing the cuff for leaks. I will intentionally add air to it and watch this cuff inflate. And it will hopefully hold inflation. So I add air to it and I watch it for a second or two. I may kind of touch or squeeze it just a little bit, making sure it holds air. Because what if, again, I opened it brand new from the package, but what if there was a manufacturing defect and there was a slight hole or tear here? I add air to the cuff and the cuff does not inflate. Am I going to place this tube inside of a patient's airway? Absolutely not, because again, when we inflate that cuff, what are we doing? We're sealing it into the airway. And I don't want to go through the process of putting an endotracheal tube in to come to find out my cuff is torn or blown or malfunctioning. Because then what am I going to do? I'm going to take the tube out and I have to start the process all over again. Remember, this is usually an emergency type procedure, so again, time is of the essence. We'll lubricate the end of the endotracheal tube, again, water-soluble lubricant like we talked about before with suctioning or nasopharyngeal airways. I will lubricate the end of the endotracheal tube and I will add a stylet to the endotracheal tube. Stylet. You notice this thing here kind of has a little curl to it. It is inside of the endotracheal tube. Notice it's not sticking out the end of the endotracheal tube. It is inside the endotracheal tube. Now Friday you guys got to hands-on a little bit with the endotracheal tubes, and I should have mentioned, and I don't know if Desmond did with that group, but the endotracheal tube is very, very pliable. Very, very pliable. If you're trying to place that in someone's airway, the second it hits something, what's it going to do? It's going to fold and try to move into a direct opposite direction, let's just say. It's extremely pliable. So the stylet adds rigidity to the endotracheal tube strictly for placement. Placing that endotracheal tube. But once it's in place, guess what we do with the stylet? We get rid of it. We take it out. So stylet there to make the endotracheal tube more rigid, more solid. Again, so it doesn't want to bend and twist out of the way when we're trying to place it. We'll probably do this at least once Friday is, okay, intubate, but take the stylet out and let's see how good you do, right? You're up for a challenge, okay, sure, try to do it without the stylet. Again, extremely difficult to perform. I'm not saying it's not impossible, but it's extremely difficult. And I'd rather make everything for this emergency procedure as simple and straightforward as possible so I don't run into any hazards or complications during the procedure. All right, step number 2, position the patient. Put the patient in a position so it's easy for the intubator to be able to see the airway. Remember last week we talked about sniffing position? Why do I need the sniffing? What was the sniffing position? The reason why we brought it up last week? For nasotracheal suctioning, try to line up the airway. Well, same thing. Remember where you're going to be when you intubate this patient. you're gonna be over here. Your head and eyes are gonna be over here. You're gonna wanna be able to look down through the open mouth to see the trachea, not to see the esophagus, or not to see darkness or some area that you can't see where the airway is. So you must position the patient again in that sniffing position. I know CPR sometimes talk about head tilt chin lift. Very similar. It's to keep the airway, get the airway open. But in this purpose, it's so we can visually see the airway. Step 3, pre-oxygenate and ventilate the patient. So 100% oxygen prior to this procedure being performed. So we can attach our bag valve mask system, ambu bag, whatever you want to call it, to 100% oxygen, and we will squeeze that bag, not only providing oxygen, but also ventilation to the patient. So again, picture, we're doing this because the patient is apneic. They're not breathing whatsoever. So we're trying to place this breathing tube to help them breathe. We're doing step number 3 here by ventilating that patient. Increasing their oxygen level, just like when we suction, we talk about, oh, well, not only are we suctioning out secretions, but their breath, their volume, their oxygen. I know we're not necessarily suctioning right now, God bless you, but during the procedure, do you think the patient's going to be breathing? And again, I'm picking my worst case example. This is a patient who's apneic. So no, they're not going to be breathing when we're doing this. So I want to kind of buff them up with 100% O2, getting their oxygen saturations hopefully as high as possible. So it gives us some time during this procedure, understanding the patient's not breathing. The patient's not getting any oxygen during this procedure. Time. I know last week I said, oh, 15 seconds for the suctioning procedure, and I said, I know that's easy to remember at that moment in time, but there's going to be another time later. All right, here's a different time. This procedure should not take more than 30 seconds to place the breathing tube. Help me remember Friday, and I'm not going to set a stopwatch or a clock or anything like that, but when you get the opportunity to start intubating with the mannequins in the lab, just imagine how much time you have actually to look and see it, okay, now I need the tube, style it inside of it, and place it into the airway. How much time is going to elapse? I promise you, maybe the very first trial at it, at least 60 seconds, if not longer, right? At least. Again, but the time frame, and it always happens. If somebody's paying attention to the clock going, okay, ready, mark, set, go, by the time you finally get positioned and you see, I see the airway, I see the vocal cords, time. So that means, okay, let me stop, and now I gotta ventilate the patient again. Build up their oxygen saturation, probably for at least another 30 seconds, and then we can try again. And it may take you, again, another 30 seconds just to finally, oh, I see it, time. Oh, now, every time I see it, I have to stop, and we gotta start back over again. So being mindful of that 30 seconds. It might not seem like a long time, but when you're involved in the procedure, it will go by very, very quickly.
So does the 30 seconds start when you take them off the oxygen to
The
place
second you stop ventilating them, the clock starts. So you have to grab your laryngoscope, you have to place it inside the airway, open things up. Hopefully everything opens up the first try. Sometimes it doesn't. Sometimes you're moving, you're wiggling and kind of get it into position. Can't see anything. Suction. Let me suction. Oh. Tube. Time. Oh, damn. Got to start all over again. So it can be stressful, and I'm not trying, in the lab, I'm not trying to create a stressful environment because that's our opportunity to practice this and get a little more comfortable with it. But it is something to be mindful of. It's great if you place the tube, but it may have taken you 2 minutes to finally place it properly. You know, what happened? What happened to the patient's oxygen saturations for the last minute and a half? You know, were they really tanking? Were they really falling at that point?
Hold your breath.
Yeah, there you go. By the time you pass out, my poor patient, yeah, think how they must feel. So again, bag valve mask ventilation, making sure we maintain a proper seal, because if I don't have a proper seal on this mask, I'm really not giving all of the breath to that patient. I'm not giving all of that oxygen to the patient if I don't have a good seal. So that's something I'm gonna, at least for me, I'm gonna be nitpicky with my group. You can't intubate until you can get a good quality BVM seal so you can ventilate the patient. And it is nice with the mannequins that we have, because you can see the lungs filling with air, or you can see the lungs not filling so much with air. All right, 3 steps. 4th step, now we finally get to insert the laryngoscope or the laryngoscope blade. Now, these steps are very important, especially what hand I can manipulate and hold with. I didn't ask in this example who's right-handed, who's left-handed, because in this case it does not matter. These blades and handles are designed to be held in your left hand, which the majority of the population says, well, that's my weak hand, I feel more comfortable with my right. I know you would, but you're going to use your left, because that is the hand you will be holding the laryngoscope blade. That is the hand you will be displacing the patient's epiglottis to be able to see the vocal cords. And again, you could say, well, but I'm not left-handed, I'm right-handed. Doesn't matter. These things are designed to be held in the left hand. Partly because of the angle of the blade, it's designed, notice the shape here, it's designed to, when placed on the right side of the mouth, helps to move the tongue out of the way. Question somebody may be asking, why don't they make left-handed and right-handed laryngoscopes? Because then we're hunting. All I have is left-handed and I'm right-handed, or vice versa. So they're all universally designed to be held in your left hand. And we'll find out Friday who needs to do some more curls with your left side as opposed to your right side. Right hand will be used to open up the patient's mouth. Now open up the patient's mouth so you can get the blade and the laryngoscope inside their mouth. It's inserted on the right side of the mouth. Like I said, we'll displace the tongue ever so slightly to the left to get the tongue out of the way, because the tongue can obstruct our vision, can obstruct our view. Step number 5, we will visualize the epiglottis. Fancy way to say, I want you to see the epiglottis. This is not a blind procedure where I don't see anything, but I'm going to place it anyways. No, that's not how this works. You must see it. If you don't see the glottis, then don't place the tube. If you do see the glottis, then do place the tube. Again, part of that 30 seconds, I'm still looking, I can't see it, I can't see it. You know, that 30-second clock is still counting down. So the blade itself, and again, this is part of practice for this Friday to see the depth of how far that blade needs to be placed. Some folks on Friday will put it too shallow, some folks on Friday will put it too deep. It's a matter of finding how far in does that laryngoscope blade have to go. It does have to go past the tongue at the very least. It does have to go past the tongue. Let's see, we'll go over some examples. So this is the view. This is what I want to see. This is what I want you to see is those vocal cords before you take that tube. Because when you're looking and you say, okay, I see it, give me the tube. All right, you better see it because I'm not putting this tube in blindly. Which pipe, 2 options, trachea or esophagus, if you were to blindly insert this tube, where would it end up probably 99.9% of the time? In the esophagus. Great, you connect that to your bag valve mass system and you can blow up the stomach. Yeah, I need lots of oxygen in my stomach for gas exchange. Of course not. I need it to be into the lungs for gas exchange to occur. All right, so how do we displace the epiglottis? Well, we have 2 options. 2 different styles or designs of blades here. They're known as the Miller blade and the Macintosh blade. Whichever blade you choose, then you have to know where it needs to be inserted to, because each one is unique, each one is different. The Miller blade will directly touch and lift the epiglottis. All right, the Miller blade will directly touch and lift the epiglottis. The Macintosh blade, so there's the Miller blade, touching the hold of the epiglottis, and when properly positioned, when lifted, will displace and show the vocal cords. Will display the glottis. The Macintosh blade, that one has the curved to it. I'll bounce back 1 slide here. Macintosh blade has the curve, the Miller blade is the straight blade. The Macintosh blade fits into the vallecula and indirectly lifts the epiglottis. The vallecula lies between the base of the tongue and the epiglottis. Okay, that was something we talked about in cardiopulmonary A&P, and like, all right, whatever, I gotta know it because you say it, I have to know it, John. Well, this is if we're using the Macintosh blade. That blade itself better find its way to the vallecula, because that's how you will then lift and displace the epiglottis. indirectly lifting and displacing the epiglottis. You will then lift the blade. Now you can see the way the handle is positioned, right? You will lift the blade. If I was going to use an arrow here, I'm following wherever that blade is, take it straight up, that same direction. So if I'm holding it, use this as my example. If I'm holding it this direction, I'm lifting that way. I am not lifting like this. This is a bad technique. When I'm ready to lift, I lift. I don't rock, right? I don't rock. If I was to rock with that blade, which I should have opened this when I talked about the blades, what are they made out of? Metal. Metal. There's some that could be a hard plastic, but generally they're metal. If I rock that blade, so instead of lifting, this person was to rock, what are they using to gain leverage? The front two teeth.
I was about to ask, are teeth going to get broke, or could they be?
If you do a poor technique, you can easily break someone's teeth. Easily. And that's where I'm talking about people like, I got to do a few more curls with my left arm because, again, it tends to be our weaker arm if we're right-handed, right? And you have to lift, but you can't rock, right? That's something we'll get to experiment with this Friday. It's always the safety of the lab, as I say, is fun when I see how many people will need to have a good oral surgeon on standby for their patients because they want to do this as opposed to lifting, right? Because you're breaking your patient's front two teeth. If you break someone's front two teeth, figuring we're talking adults here, are they going to have those front two teeth anymore? No, they're going to have to see a good dentist and have some artificial ones placed, but they will not have those front two teeth. They will break. They will easily break. And every time I do this lecture, every time I talk about this, about not rocking on the teeth, I'm going back to the first time I ever saw someone do that incorrectly.
Oh my God.
18-year-old patient, 18-year-old young lady in the ER. Doc was the one doing the intubation. And it's a sound I can never, ever forget. You know, if you just picture metal on teeth, that breaking, that crack, I can still to this day feel it in my spine, you know, because I imagine it must hurt so bad. The patient needed to be intubated. The patient was coding. We'll go over the whys later, but so needed the emergent airway. But yes, those front two teeth were now gone.
You're making mine hurt and they're already fake.
I know. Exactly, trust me. Mine too. Oh, I forgot I added this here. This rule of thumb, the number 3 curved Macintosh blade or straight Miller blade are the typical size blade you will see with an adult patient. And of course, there is going to be a laundry list of, okay, what if it's not an adult patient? What if it's a neonatal or pediatric patient? What size? Well, there's a whole laundry list of sizes, and I don't want to get too involved in just the numbers today. But for an adult, it is important to know the size of the blade. I'm going to bounce back a couple pictures here. The very first one. Everybody see that? I know it's difficult to see. It says MIL2. And you know it's a straight blade, so whose blade is that? It's Miller. It's a Miller size 2. This says MAC for Mac 3. So the sizing of the blade is written somewhere on the blade. Sometimes they may be on this side that's not pointed toward us. Sometimes it could be on the back end, or sometimes here it could be on this side to let you know the size of the blade.
To know which one you're gonna use, it's more which hospital use.
Great question. So does it make a difference, the Miller blade or the Macintosh blade? Yes. The whys I won't get into just yet because I want you this Friday to experiment with both. Okay? And what's going to happen, and I probably can put a line down the middle of the classroom and go, half of you guys will probably prefer to use a Miller blade, and the other half would probably say, yeah, I'd rather use the Macintosh blade after getting an opportunity to practice with it and see how it feels. See how it feels in your hand, how it feels to lift and raise. And it's really a personal preference by the intubator.
There's nothing to do with the anatomy of the patient.
I don't want to spoil the surprise and make any opinions of anybody just yet. Remind me Friday, I'll tell you then why one would choose one or the other. Or if I don't see you Friday, next week, ask me, because I don't want to create any opinion.
Okay.
I really want to see, how does it, to you personally, which one do you prefer, okay? And there's no right or wrong answer. When we work with our physicians, of course, most of the critical care physicians, pulmonologists, anesthesiologists, they can all intubate. Respiratory therapists, depending on our institution, respiratory therapists can intubate. Sometimes in some institutions, they only select a certain amount of respiratory therapists. You go through the training, that can intubate. Some places, the respiratory therapists are not allowed to intubate. It's strictly the docs who intubate there. So it really depends on the hospital as far as who gets to do the intubation. Of course, we need to be familiar with it and understand and know, because even if we're not the one actually lifting and placing the tube, we are right there at the bedside assisting and participating in the process of intubation, even though I might not be the one with the blade and the tube. And some people may say, well, thank goodness for that, because I'm afraid I may rock and break someone's teeth. Well, okay, well, I'm glad that's not going to be you. But nevertheless, whoever is doing the intubation, more than likely, he or she has a personal preference. And so if we're getting set up for intubation, and I know Dr. Such and Such is going to be doing the intubating, you may know what their personal preference is, but you might not. You're setting up everything you need, all that equipment we talk about, all that stuff being set up there in the room, waiting for Dr. Such and Such to show up. And when he or she shows up, Doc, would you prefer a Miller or a Mac? Give me the Miller. Okay. And now you know what blade the intubator is preferring in this example or in this case. And there's also a fair share of physicians that may have one preference, but then based on certain factors I'm yet to discuss or disclose, choose the opposite one. Okay, but we'll get into that in due time. So, you're lifting, not rocking. We're not rocking on the teeth. We're lifting up, and that's going to expose what? The vocal cords. So we can see the vocal cords, because that's our target. We're going to place that tube through those vocal cords. So again, what hand am I holding the laryngoscope and blade in? Your left hand. Now with your right hand needs to be doing something. Now you can have hold of the endotracheal tube, stylet already inside of it, cuff that's already been checked and verified that it's working properly. Now with your right hand, the endotracheal tube is inserted from the right side of the mouth to eventually end up past the vocal cords. Now I kind of added this, you guys have it on the PowerPoint, but do not follow the channel of the blade. I've seen some students, and we'll, again, practice this on Friday, but I've seen some students that when they have the laryngoscope in their hand, they think they have to take the endotracheal tube and basically slide it down, touching the laryngoscope. You don't have to do that. You don't have to do that. The laryngoscope and blade is there just to displace and get the tongue out of the way. Now, if I see the vocal cords, I can simply just place the tube past it. I don't have to guide it down the channel of the laryngoscope blade. We should see the endotracheal tube go past the vocal cords, go through the vocal cords. If you don't see it, then what are you doing? You're doing this procedure blind. Might as well just cover your eyes and hope for the best, right? No, we're going to see it. And if we don't see it, I'm not going to place the tube. It's simple as that. I could say, well, I don't see anything. Okay, let's stop for a second. Let's bag them, get their oxygen saturations up, bag them for another 30 seconds or so. Okay, let me try again. And you know, at some point, I just can't see it. Okay, well, let's somebody else have a shot at it. Maybe they can see it. Again, so we're not doing this blindly. When the tube is in place, so what I mean by that is the tube has passed the vocal cords. It is where it's supposed to be. You see it in the right spot. You still have the laryngoscope in your left hand. The tube is now in its proper position. Do I just drop everything? Done? Next? Give me my money, right? So, tubes in your left, or excuse me, laryngoscope and blades in your left hand, tubes in your right hand. It's in the right spot, okay? Now guess what I don't need anymore? I don't need the laryngoscope and blade because the tube's in the right spot. So with my left hand, I will then set the laryngoscope and blade down. With my right hand, I'm continuing to hold the endotracheal tube. There's no guarantee that tube's not gonna slide too far out or too far back out. Or what if the patient starts moving around? I need to have hold of that tube with my right hand. Again, left hand, I don't need the laryngoscope anymore because I got the tube in the proper position. So the laryngoscope can be pulled out of the patient's mouth and set to the side. But I am gonna hold that tube with my right hand. Now with my free left hand, guess what I'm gonna do with that stylet? Get rid of it. Get rid of it. I will remove the stylet. We will then add air to the cuff to seal it to the airway. And that's what, again, this is not a one-person show. This is what part of the team is assisting. So like I said, even if it's the doctor who's actually doing the intubation, you already know the next step. You already know what's happening next. That they're going to be removing the laryngoscope blade and handle. They're going to be removing the stylet while you're doing what? Adding air to the cuff. The cuff that you've already tested and checked to make sure it's working properly. So air is being added to the cuff. At that point, it's now sealed in the airway. Someone, whether it's the intubator or now someone assisting, one of the other RTs, still has to have hold of that tube so we don't lose its position. While we then attach our resuscitation bag, we don't need the mask anymore that we needed in the beginning. Don't need the mask anymore. I have that resuscitation bag. Now it's connected to the endotracheal tube and I can start ventilating and oxygenating the patient. Any questions? Step 7. All right, step 8, assess tube position. Now the tip of the tube, when it's properly placed, should be approximately 3 to 5 centimeters above the carina. If it's too far down, we know, we already talked about it. If it's advanced too far, it's more likely to end up in the right main stem. And now I'm ventilating the right and not the left. But when it's in proper position, we should see that the tip of the endotracheal tube is 3 to 5 centimeters above the carina. Now, at this point of the process of this procedure, we're kind of doing step-by-step method, I won't be able to know that visually by me placing the tube. Other than the fact that I know when I advanced that endotracheal tube past the vocal cords, I made sure not only was the tip of the endotracheal tube past the vocal cords, but so was that cuff, the deflated cuff. I made sure all of that cleared the vocal cords. When I ultimately will find out this location, it will be after the end of the procedure when we get a final chest x-ray to make sure it's in proper position. And the chest x-ray will tell us where it is in relationship, the tip of the tube is in relationship to the carina. Now what we can find out once the tube is placed is those centimeter markings that we were looking at this last week, those centimeter markings, where are they? Now we know around, for males, around 21 to 23 centimeter mark, or females around 19 to 21 centimeter mark is approximately the depth of the tube. But just because I can see my placement is at one of those markings does not tell me that that tube is in the trachea. Because what if the tube's in the esophagus? Couldn't I make sure it's at 22, 21 centimeters? Sure, but the tube itself is in the esophagus. So that's just one piece of the steps here. If it is in the trachea, approximate location in those low 20s for a male or female. But every patient is going to be a little bit different. Just don't take those numbers, and if it's not those numbers, that, okay, it must not be far enough or it's too shallow. No, every patient is different. Once we get that chest x-ray that confirms placement of the tube in relationship to the carina, then I know for that patient, that's where that centimeter marking should be, and I will document it so everybody else from here on out knows that's where that tube should be kept at. This third one, very important, listen for equal and bilateral breath sounds as the patient's being ventilated. I didn't say you're going to hear normal breath sounds, but you should hear air moving into the lung. And it should be equal and bilateral, not right side inflation only and only hearing sounds on the right side, because again, that means the tube's been pushed too far. I should see symmetrical and equal chest rise. As I'm listening, I should see equal breath sounds. The next one, observe chest wall for adequate and equal symmetrical chest rise or expansion. So as I'm listening, I'm also looking, and I should see the chest rising and falling equally. Okay? And again, breath sounds being equal on both sides. Last thing here, if it's in the airway, we will attach a carbon dioxide detector on the end of the endotracheal tube. That will be found between the endotracheal tube and my resuscitation bag that I'm squeezing. And I will see it change color. I'll show you what it looks like here in just a second, but you will see it actually change color to signify it's measuring exhaled carbon dioxide, which we don't have carbon dioxide in our stomach. So if it's in the lung, and even though the patient might not be breathing on their own, if I'm squeezing that bag and then I release it, allowing them to exhale, because exhalation's passive, they're exhaling carbon dioxide, I will see that CO2 detector change color. All right, step 9, stabilize tube and confirm its placement. I'm sorry, go ahead.
If you like put the tube in too far or too shallow, do you have to start over, or can you just like adjust it once it's like in there?
Are we in the trachea?
Yeah, like, but like if we have like a mainstem innovation, or if it's like not as deep as you would want it
Okay,
to go.
as long as it's in the trachea.
Yeah.
And the shallow part makes me wonder, right? But as long as we're still in the trachea, I don't have to pull the tube out. I can, if it's just too high, I can advance it. If it's too deep, I can pull it back and not have to extubate and start the process all over again. But has to be in the trachea for me to do that. Don't secure the tube until correct placement has been determined by listening to the equal breath sounds, seeing equal symmetrical chest rise, seeing your CO2 detector. I'm not saying chest x-ray just yet, but once I have listened, once the intubator says, yeah, I saw the tube go past the vocal cords. I see equal chest rise, I hear equal breath sounds, I see good color change on that CO2 detector, then I can begin securing the airway. And there's different methods, there are different ways to do it. We could use good old-fashioned tape, but the tape can't be cloth paper tape because it doesn't hold well enough. It does have to be a good quality tape. No duct tape or anything like that, but it does have to be good quality tape. Darn it. Trust me, duct tape would hold really well, I'm sure. But we do have to take it off from time to time, and that's probably going to cause some problems, right? They do make, and a lot of places will use these pre-made endotracheal tube holders. Okay, we'll get into those and how you place them later. Go ahead.
So we're concerned about, potential for infection or stuff holding bacteria and stuff.
Yeah.
Obviously, they're not using duct tape, but tape, period, that could potentially harbor.
Potentially, but it's not. But the tube has to be secured.
Yeah.
Unless we're going to pay somebody for the next week, 24/7, to hold that tube to make sure the tube does not become dislodged. All right, so the tube does have to be in its proper position.
I was just saying, like, I'm shocked that they would say tape versus, obviously, there are other things that hold it in place.
Yeah. It does, and
Just
to be
depends
honest,
on
it
the-
doesn't matter. We need something to hold and secure that
Yeah.
tube. What you're going to find, most places do use some sort of endotracheal tube holder. There's all kinds of great benefits of having one of these as opposed to tape. But if I don't have one of these, we're out.
Yeah.
We're waiting on the shipment to come. I still can use good old-fashioned tape to secure and hold that tube in position and make it look nice. Now, again, coming from the old school where we didn't have these things, and I would have to go with students and go, okay, we're gonna tape a tube today or retape a tube today, and it has to look pretty. We can't sit there and have it look like the patient's wrapped up like a mummy. I can't tell you how many times I would have to tell students, it's not good enough. Take the tape off and let's do it again. It's happened before 3 or 4 different times, and students are getting frustrated with me. I'm like, it's not good enough. If that was my loved one, I'm not satisfied with it.
Is that one good?
Number one, it's decent.
It folds.
Yeah, it's decent. It's decent. It's decent. But I need, number one, the tube to be held secure. If it's not held secure, then it's likely gonna become out of position at some point. Does it look presentable? Does it look clean and right? If I had tape going all over this guy's face and across his nose, that wouldn't look right. Not that I've had students do it that bad before, but with tape, and I'll be honest, with tape, it was always fun to teach students how to tape an endotracheal tube, because we would do it the first time, you're not wearing gloves. Get used to the feel of it, how it's supposed to look. And then time number 2, okay, now put some gloves on. What's the tape want to do to your gloves? Wants to stick to itself or fold over on itself, and you're trying to get it all to, dang it, I can't do this. Again, it takes practice. It takes practice to become better at doing it. But today, a lot of places use, and this is one particular brand, there's all kinds of other brands that are out there, but that's a really popular one. Goes by it's a brand name called Hollister. Like the clothing line Hollister, not made by that same company, but they call it a Hollister.
Will we do that in lab? The tape part?
Yeah.
Okay.
Yeah. Not this Friday, not
Oh,
this
yeah.
Friday, but in time. All right, so just quick review of the steps. So to verify proper endotracheal tube placement, in order, step number 1, visualize the tube going past the cord. That always has to be the first step. The intubator saw the tube go past the vocal cords. Step number 2, 3, and 4. And again, I put them in a particular order here, but these are all really done all at the same time. So I'm not going to be nitpicky if I tell you, give me write a list or multiple choice question, which one of these steps is the right order. These 3 things are done all almost sometimes simultaneously. See and equal chest rise. Listen in the breath sound. Sometimes I'm listening to the breath sounds, looking at equal chest rise all at the same time, right? CO2 detectors. I'm listening, somebody's putting the CO2 detector on, we're seeing color change. All 3 of these are all happening almost simultaneously. All right, but those are all 3 important. I'm not skipping any steps. All 3 of those are important. Last and final step, just like this is the absolute first step, chest x-ray is the absolute final step to verify proper tube placement or proper tube position. Now, let's just hypothetically say the first 4 we didn't really do. We didn't really do it. We didn't really look and verify that it's equal chest rise or breath sounds. We forgot to check to see with the CO2 detector or the intubator, who knows what they saw. Really didn't do any of these. Are we safe to say that, well, if we wait and get a chest x-ray, we'll know for sure if it's in the right spot? How long do you think, hypothetically, it takes to get a chest x-ray after we've intubated someone?
Depends.
A while.
Could be a while, could be a few minutes for x-ray to come down there, come in the room, get things set up, get that x-ray, get it to the imaging so we and the physician can take a look at it, radiologist can get a chance to take a look at it. It's something that's not going to happen in the next 30 to 60 seconds. It's going to take time.
So potentially they could be
Sometimes
deprived of oxygen?
Exactly, and that's what I'm getting at. I can't wait until this step to make sure it's good, it's in the lung. No, I needed to make sure up here. All the x-ray is going to let me do is where is that at in relationship to the carina? Is it 3 to 5? Is it at 1 centimeter to the carina? Is it 10 centimeters above the carina? That's all that's going to let me know. Okay, but I know it's in the lung based on these first 4 steps.
A lot of times, and that's what's so great about like teamwork when it comes to this kind of thing, is that like our charge nurse, when they find that someone's about to be intubated, they call ahead of time. It's called
Absolutely,
take ahead of time.
absolutely,
That way.
absolutely. But I don't want us to wait for x-ray
Yeah.
and not do these first 4 steps.
I know that when they call a code or whatever they're doing that is one part that's required to show up.
Yeah,
At,
yeah. But again, it's not, but the result
Yeah.
of that x-ray is not gonna
Yeah.
happen like that.
No, yeah.
Right. All right, so this Friday, what are we practicing, doing, performing? Intubation. And I know it's taking me how long? 40 minutes to sit there and go over all the steps, at least up to this point, right? And am I gonna be in your ear Friday going, do this, don't forget that, don't do this. Again, it's gonna take practice to get comfortable with all the steps, right? Of course it is. But probably the most challenging step is the actual displacement of the epiglottis and the placement of that endotracheal tube. So, it's not in the PowerPoint that I posted, so sorry about that. But we'll see how this looks. So right hand to displace, open the mouth, left hand's holding the laryngoscope and blade, getting that past the tongue, lifting, displacing the epiglottis. You see it? Whoop, there we go. Lost it for a second. Okay, there we go. You are seeing the ET tube and cuff go past the vocal cords, correct? That's what I want you to see when you are.
Watch it again.
Of course. I'll post it. I'll post it if you want. Replay. Please do. Slow-mo. So when you intubate this Friday on the mannequins, this is what we should be seeing. There's a uvula, right? A little dangly thing. They're lifting, lifting, lifting. Notice they're not rocking on the teeth. Again, still, they have not rocked on the teeth. Advancing that tube into position. Okay? So, of course, all the steps will then follow after. Again, getting rid of the laryngoscope, taking the stylet out, somebody adding air to the cuff, somebody adding the CO2 detector and the bag valve system, we don't need the mask anymore, to the endotracheal tube to start looking for equal chest rise and listening for breath sounds. So, kind of the slow-mo here, as they lift, that's what we're seeing. If I don't see the vocal cords, my placement, whether it's the Miller or Mac blade, is not probably in the right position. Like I said, most times students will go too far or too shallow. But that's part of this Friday's activity, is to get comfortable with how far in does that laryngoscope have to go. And I do, regardless of which one you eventually say, oh, I like this one better, as far as blades go, get used to with either or. Because again, the placement's gonna be slightly different with the Miller blade or the Macintosh blade. Again, ultimately, that's our target. That's our target. And you seeing the endotracheal tube go, and cuff, go through and past the vocal cords. All right, going back, just re-hitting some of those steps. Seeing it go past the vocal cords. All right, seeing the tube go past the vocal cords. I call that visualize the glottis. Visualize it going through the vocal cords. I did not use the word imagine. I imagined it's going past. No, you actually visualize it. You actually see it. Our CO2 detector.
What was that on that? What is that? That looks like.
Little bar.
That's the blade.
Oh, okay.
That's the blade. They also have a scope going down to get the image of this going through. So yeah, that's the top of the
Okay.
the end of the laryngoscope blade. All right, so the CO2 detector, notice where it goes. It's gonna be between the endotracheal tube and the bag system, the resuscitator bag system. And so when you squeeze that bag, you're obviously gonna provide oxygen, but when the patient exhales, they're gonna exhale through this CO2 detector. The CO2 detector is really litmus paper that can tell us the pH of the air, which is an indirect method to measure exhaled carbon dioxide. And so it's going to transition between two colors, between yellow and purple. Between yellow and purple. So when you're looking for color change, you're going to see it change between yellow and purple, purple and yellow, depending how the breath is either going in or going back out. So let me kind of do the animation here. So when you squeeze your resuscitator bag and oxygen goes through that detector, notice what color it's going to be. Purple. When the patient exhales and it turns yellow, they're exhaling carbon dioxide. Okay, so you'll see it every time you're squeezing that bag and releasing and the patient's exhaling, you're going to see this change
Inhale
color.
purple, exhale yellow.
Yes, yes, yes. I had to think about it for a second, yes. A lot of times people they'll look at it and go, yep, there's a positive color change. Great. You know, because it's not, if it's going to change color, it's not going to work in the opposite fashion. Okay?
No, will it always be those two colors?
Yes, yes. All right, so we're seeing it turn yellow. I know that's exhaled CO2. Now, let's just hypothetically say the intubator thought they put the endotracheal tube through the vocal cords, but they didn't. Again, is I'm checking color change, but again, at the same time, I'm looking for equal chest rise and fall and equal symmetrical breath sounds. Meanwhile, I don't see it change color. If the tube is in the esophagus, guess what it's not going to do? It's not going to change color. You may squeeze it, it turns purple. You release it, it's still purple. Again, because there's not CO2 in our stomach. I will say there can be some rare circumstances where if the patient was just consuming a carbonated beverage right before we intubated, there's some CO2 in the gut. Okay, that could possibly make it change a little bit of colors. But there's also a few other times, and I don't get too much into the how it may happen on rare occasion. Right now, we're just talking about how it's supposed to work, how it's supposed to be. If it's not changing color, the tube's not in the trachea. Okay, the tube's in the esophagus. If it's not changing color, the tube is not in the trachea. It must be in the esophagus. All right, the chest X-ray confirmation again. That's why we have that radio-opaque line on the endotracheal tube. It will appear on X-ray. Again, when we see where that line goes to, and we can see the carina, again, should be 3 to 5 centimeters above. If it's too much lower, even though it's not necessarily going in the right main stem, that's still too low. The tube, believe it or not, still can, even though the cuff's inflated and there's tape, the tube still has a possibility of moving up and down in the trachea. And so I want to give a little bit of wiggle room there. If it does slide down a little bit based on patient movement, it has a little flexibility and still is not going to hit the carina or go into the right or left main stem for that matter. Yes?
Usually how long is like, how deep is from the vocal cords to the carina? Like centimeter approximately?
Oh gosh.
Because then you can.
Yeah, is there like a set
Because then you can.
preferred?
It's probably to the carina. Well, the trachea is 11 centimeters long, the trachea itself. The vocal cords are in the larynx, which is sitting just on top of the trachea, so I would probably gauge 11 centimeters for the average adult patient. But every one of us could be different heights, which could change that number ever so slightly.
I know that in you have experience, you might just see the number of the lip and then advance 5 or 6 centimeters.
Possibly. But all we're seeing right now is that tube and cuff going past and through the vocal cords. I turn the light off just because sometimes these images are hard to really see. Tip of the endotracheal tube, the carina. On my screen, it's actually not much, but a little bit better than the projection that I'm showing here. But again, if it's labeled like this, then obviously we can see its placement. I think I have another one here, again, pointing to the carina. These are obviously not the healthiest patients in the world. Notice, is there much air inside their lungs? Notice how white. Air should be darker in color. There's so much white in here, so these are already lungs that are pretty bad, hence why they needed to be intubated. But there's the tip of the endotracheal tube, there's the carina. This one, the tube, I gotta step back for a second.
That's like a
Okay.
right stem.
There's the right, there's the
I
left,
can see it.
there's the carina. And sometimes I'm being too close, so I gotta step back. There's the left main stem, there's the right, and the carina's right here. So notice how close this is.
I noticed on that last picture that the tip of the ET tube happens to be in line with the clavicles. Is that always going to be the case, or is it just going to vary? Or is that a good?
This is a perfect X-ray because the patient is perfectly positioned.
Yeah.
Seeing the clap. Sometimes the patient gets a little wonky in their positioning here, so it doesn't always look so pretty as this one does. But that's a general good kind of tip to follow. I wouldn't want it any higher than that because it's starting to get a little too high.
Okay. So maybe just clearing the clavicle will be.
Yes. So this one, it's going into the right, but you can still see there air still is air on both sides. This one, find it. There's an endotracheal tube.
Way
Too far. We are able to inflate this lung clearly, but that lung, No, there's no air getting into that lung.
Can-
And so
how
that's
can you
causing
s-
what massive atelectasis. So remember what we're hearing with a right mainstem intubation. I can hear breath sounds on this side, no breath sounds on the opposing side.
Can you, where is the corona, where would it be? I can't tell where.
Sorry, I gotta. This one. It's hard to see it because the right lung is not inflated.
Okay.
I mean, clearly you can see the angle here. If I'm just using anatomy, the carina should be approximately in this location, but it's extremely hard to see.
Okay.
But that is definitely into the right mainstem.
And on both of these, you would just back them up a little bit.
Yes. And when we say back them up, be careful. What must be deflated first? The cuff has to be deflated. I know, and the reason being is I'll let things go in the lab so you can learn by making a mistake that I would never let you do at the patient's bedside. But if the tube's too far, and I say, oh, you need to pull the tube back. I've had students, again, in the lab, oh, okay, no, you've kept the cuff inflated. Think about what you're doing to my poor patient as you're sliding this inflated cuff back up there. No, you have to deflate the cuff first, then pull it back to whatever the appropriate amount is, and then reinflate the cuff. All right, one thing that wasn't mentioned in the textbook, I call this pro tip, is the application of cricoid pressure. Now, a lot of times the textbooks will call it the Selleck maneuver. I don't know who Selleck was, but they named it after him. I don't know if it was the actor Tom Selleck, I think it was. But the term cricoid pressure. Now, if you're the intubator, okay, so you're me, you're looking at the patient's lying on their back, they're in the sniffing position. When I'm looking down, remember the trachea is up top, the esophagus is below. Okay, so when we displace the tongue, it's so we can see the trachea better. If we apply cricoid pressure, which if you find a patient's cricothyroid membrane, and you simply gently push down, remember what I'm looking at here, trachea, esophagus. If I can push down, or have an assistant, I should say, not myself, an assistant push down on the cricoid cartilage, it will, again, trachea here, esophagus here, what will it do to the trachea? It will bring the trachea down. Hopefully it's a little bit easier for me to see it. Added benefit is because there's just tissue between the trachea and the esophagus. I can use the cricoid ring, cartilage ring, to actually push down and compress the esophagus, which helps to prevent anything coming up from the gut or stomach from getting back here that could potentially turn around and go into the patient. So a way you can think about to maybe prevent aspiration during the intubation, applying cricoid pressure. But I want you to remember that technique. Don't have to do it every single time, but if you know we're going through a situation where it's a challenging, difficult intubation, and trust me, in practice you learn all kinds of little tips and tricks to make things go a little more efficiently. Applying cricoid pressure may be one of those. I had a student one time, again, this was a second year student. I'm not doing clinicals with you guys, but she called me after her clinical and she was so excited. I said, well, what's up? What happened? What'd you see? What'd you get to do? She goes, well, we were intubating a patient today and it was an extremely difficult intubation for the physician to do. And the physician was struggling. And my student, I'm so proud of her, my student who was there bagging the patient between intubation attempts by the physician, when she saw this physician struggling so much, she said, are you okay if I apply cricoid pressure? The physician's reaction was, oh yeah, did that, got the patient intubated. Wow. I was so proud of her for being brave enough to even bring it up, to even mention it.
I'd be like, did you mention what school you went to?
Did you mention my name? No, but it was great. I was proud of her for doing that, and just recognizing the situation. And it was a difficult, challenging intubation for the physician to place that tube. And I'm assuming that it was a he. I'm assuming he just forgot, didn't recognize. And again, I don't know who the physician was. I don't know how young or inexperienced maybe the physician was. But just one of those things. That be brave enough to mention it. If they don't want it, they'll be more than willing to say no. And we'll go from there.
On a man, would it be above or around the level of the abdomen?
Right around. just talking about nasotracheal intubation, which I said, don't touch yourself. Chad gagging over there.
Just trying
Right.
to see, let's.
So everything we mentioned so far deals with orotracheal intubation. That's going to be the primary method. That's what we're going to see most of the time. The rare occasion you encounter either the actual process of nasotracheal intubation or just that you're working with a patient who is already nasotracheally intubated. Understand sometimes the reasons here. So again, not the preferred method by any means, but sometimes it is necessary if something's going on with the mouth that would not allow us to place the tube orally. Maybe they have had oral surgery, something's going on, some sort of maxillofacial injury, trauma, something like that. Then maybe we have to place the endotracheal tube nasally. Now this comes from personal experience as a nasotracheally intubated individual, okay? I was intubated. I was nasotracheally intubated. I told you guys I was a former baseball player, right? I played baseball back in my day. Oh no, yes. Oh no, yes. It was during a baseball game. I was the leadoff hitter. I was first batter of the game. When I was doing some swings in the on-deck circle, I watched the pitcher warm up and wasn't overly impressed, but he threw a curveball. And I'm like, oh, please throw that to me, because I'm going to turn on it and I'm going to hit it out of the park. And so first pitch, I think, was a ball. Second pitch, what I thought was a curveball. Now, for anybody that's never played baseball before, being a right-handed batter against a right-handed pitcher, when they throw a curveball, the ball looks like it's coming right at your face, and then as it approaches the plate, starts to break and curve. And it's a big ego thing that if I'm a right-handed batter and somebody throws a curveball, that my knees buckle or that I duck and try to get away from it. So I'm like, I saw you throw this pitch as you were warming up. I'm going to sit and wait, and I'm going to wait for it. I know it looks like it's coming at my face, but I'm going to wait for it to break here where I'm going to turn on it and hit it out of the park. Unfortunately, the curveball I thought he threw me was not a curveball. It was a fastball right at my face.
So you were getting
And
cocky.
so, what's that?
Cocky.
No, by no means. So, definitely not after this. So the ball, once I recognized, oh, bleep, 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 it's not going to curve, again, to get out of the way, all I do is turn my head. Well, again, we're in a helmet and an ear flap that goes here. As the ball's coming at me and I turn, which I was turning the right way, I'm turning away from it, it caught me right here. I have it on video still to this day. It's hard to watch sometimes because you can hear it. You can hear the, and they're like, did that sound like it hit your helmet? I wish it did. No, it hit my face. It hit my jaw. Broke my jaw here and here. It hit so hard. I did a kind of a 360 kind of drop to my knee there, and maybe I was a little cocky, arrogant SOB, but I was the fastest guy on the team. And so coach, every time I would get on base, coach didn't even give me the signal anymore. He'd say, John, steal. And so first batter of the game, second pitch of the game, coach comes down. Can you run? I let him go. It hurt so bad. It hurt so bad. I would have been arrogant enough to go run to first base and like, I can handle it, but it hurt so bad. And after a few seconds, I feel stuff in my mouth, so I expectorate. It's bright red Frank blood. So knew that was not a good view. And I couldn't appreciate it other than, again, everybody that's sitting behind home plate, as I'm down on a knee spitting, I could hear the gasp. I'm like, oh, that was disgusting. I wish I didn't do that in front of all these people. And so, get me up. They had somebody run for me, and I go back in the dugout. And again, and history then writes itself. Yeah, I broke my jaw. So for the next 6 weeks, what did they do?
Your mouth
They
was
wired
large.
my jaw shut. Okay, for 6 weeks. Wired my jaw 100 completely shut, which makes it kind of difficult to eat, wouldn't you say? So not the weight loss plan I would recommend for even my worst enemy, because anything I would consume would have to be liquid, right? Again, without getting totally disgusting and totally getting off the subject here, trust me, there was plenty of things that found its way into a blender that I was able to pull through a straw, and yeah, I wouldn't recommend it today, but boy, it tasted so good at those times. But nevertheless, so when they sent me to surgery to wire my jaw shut, how would they intubate me? Nasally intubated me. And I know that, again, I was a senior in high school, I'm 18 years old, didn't know anything about medicine, but I remember pre-operatively my nurse telling me, now when you wake up, there may be a tube in your nose, do not pull it out. Okay. I'm waking up from surgery, what's the first thing I did?
Pull it out.
I didn't pull it out, but I remember
Grab
that
for
was
it.
the last thing I remember is her instruction, do not pull that tube out. But I'm like, is there still a tube in my nose? The first thing I went to is to feel that tube that was in my nose. I was already extubated. It was already removed, so it was nothing to pull out. And I wasn't going to pull it out because I remember her very distinct, clear instructions not to pull it out, but I just wanted to see if there was a tube up there. And there wasn't, and I had already been extubated. Anyways, that's my story. So, nasotracheal intubation. Two different ways it can be performed. One is blindly, again, why probably nasal intubation is not the preferred method. One is blindly, where there is nothing for us to see. The tube is just placed nasally, and the physician, I say physician, the physician would be at the end of the endotracheal tube feeling for what? Air. Exhaled air by the patient. Okay? Because if they're not in the trachea and they're in the esophagus, guess what they're not going to feel? They're not going to feel air. So the blind nasal intubation only works for a patient who is breathing. You know, if it was a patient who was apneic, who was coding, there's no way to do a blind nasal intubation because, again, the patient's not breathing. With visualization, however, and visualization would not have worked in my case. With visualization, they would have had to open up the airway, expose the trachea, and then the tube itself, using what we call McGill forceps, would then advance it and place it into the trachea. But again, my jaw was being wired shut, and maybe they did do it through visualization, but they would have had to open my jaw. I guess I was knocked out by that point for surgery, so I wouldn't have known it. But remember that McGill forceps are necessary for a nasal intubation. Nasal intubations, for some positives, even though it's not the preferred method, some positives, it does allow for improved mouth care. Now, it doesn't work in my case with the wired jaw, but you know, to get in and be able to clean, do better oral hygiene for the patient, be able to brush their teeth, etc. Complications, God bless you, can include epistaxis. Anybody know what epistaxis means? Nose bleeding. Again, the nose is very vascular. Sinusitis or otitis, kind of a middle ear infection, because it can prevent some drainage coming from the middle ear. So, not perfectly 100% better than orotracheal intubation, but there is some very specific certain situations where a nasotracheal intubation must be the choice. What if the patient, again, mine was just a broken jaw, I mean, minor by comparison. What if they were in a horrible trauma accident and part of the jaw was missing or gone or really damaged? Again, then maybe nasal intubation would be their only route.
I'm curious, how is nasal intubation help with improved mouth care?
Because orotracheal intubation, you have the tube in the mouth. And so it's going to be harder, and think about the tube holding, the tape, all that stuff, to get in to be able to clean the mouth, do better oral care, to be able to brush the patient's teeth.
Okay, I'm just thinking like
prevent bacteria from building up.
Obviously, it's not. They're not doing nasal, obviously, just for if the mouth is wired shut. So that's why I was like, mouth's wired shut. How are you gonna do oral care anyway, other than just?
Right.
But okay,
All right, so picture there on the left, someone doing a blind nasal intubation. Notice how close their face is to the patient's endotracheal tube. What if the patient was to blow stuff out of the endotracheal tube? Right there on the patient's face as they're trying to feel for air, trying to feel for a breath. There's the McGill forceps, and they are pretty big in size, that would actually grab hold of the endotracheal tube and be able to put the tube in its proper position, but still would require visualization here. So would require a laryngoscope blade and handle to be able to displace, be able to get that forcep into the mouth and into the oral pharynx.
So how deep is it going? Because it doesn't look like it's going great.
Well, it's still in the process of being placed. It would eventually, so Something else, and I should get a better picture of it here, I will do it in time, it doesn't help you guys right now, is when you have someone orally intubated, okay, approximately how far out of the mouth is the tube gonna be? Okay, is the tube gonna be all the way in the mouth? No, it's gonna be sticking out of the mouth. Now, is it gonna stick out of the mouth this far? No. So oral tracheal intubation, again, without being scientific here, giving you any numbers, about yay far is going to be outside of the mouth, as far as how it should look. When you walk into the room and you look at the patient going, okay, that looks right. Yes, I'm going to still check the centimeter markings and verify positioning and all that other stuff. But as far as just visually, initially, how it looks. I say that because, and maybe if I didn't say it, more of it would happen this Friday, but I've had students before during the Friday intubation lab put that tube all the way in where you'd only see the 15 millimeter adapter barely sticking out of the teeth. Going, all right, that's too far. That's going to be a right main stem. But like I said, I let things go in the lab, let it happen so you can see what it looks like. But no, it needs to be kind of out. A nasotracheal intubation, that tube, when you're looking, where's my, oh, this piece. This end is going to be all the way right there in the nostril. All right, meaning the tube, again, a little bit further distance nasal as opposed to oral to get into its right position. But ultimately here, it's going to be in its normal position where it should be, even if it was an oral tracheal intubation. All right, any question about intubation with an endotracheal tube? All right, let's go over a few things. Tracheotomy. Tracheotomy is the surgical procedure for establishing a trach through an incision in the trachea. All right, so we'll talk about here in a minute some of the different types of tracheostomy tubes, but just the verbiage here. A tracheotomy is the surgical procedure, cutting the neck to create an opening here for a tube. Now the opening will be referred to as a tracheostomy, so sometimes they'll say tracheostomy procedure, or a tracheostomy tube, or a tracheotomy tube. Again, tomato, tomato, it's all related to the same thing. That's that airway that's being placed into the neck. But it's a surgical incision being placed into the neck. And who puts the surgical incision? A doctor, a surgeon, or a physician, not the RT. Sorry to disappoint anybody, but no, you're not going to have to get a scalpel and cut on someone's neck. It's funny to see everybody's reaction. Some people are like, oh, thank God. And others are like, oh man, I wish I could. Tell me the type of person you really are.
When you watch like this medical series that they get like a pen and
Absolutely, absolutely.
Save a life.
I carry my pen with me wherever I go, waiting for the moment I can actually put this in and breathe through someone's neck. I'm joking. Yeah. All right, the different types of tubes, there's different types based on patient's age, their height, their weight, even airway anatomy. We're not all exactly the same shape or size when it comes to airway. All right, indications here for a tracheotomy or tracheostomy tube placement. This is the preferred, this is the preferred primary route if a patient has an upper airway obstruction or upper airway trauma. Okay, again, it provides a more secure, better airway when you have this specifically already being placed in the trachea. Number two, for patients with poor airway protective reflexes, those that can't cough adequately, can't clear their own secretions adequately, again, to prevent aspiration, they may place a tracheostomy. And then number three is where we tend to see this more commonly considered if the patient still needs an advanced artificial airway, like an ET tube, after approximately a week or two. So, picture this is our patient. We got to intubate them, and we placed an endotracheal tube in them, we connected them to the mechanical ventilator, and they're our patient now. And we've been taking care of this patient all week. And the likelihood of them coming off the ventilator in the next few days is getting more doubtful and doubtful and doubtful. Their situation's pretty serious. They're going to need the ventilator maybe for several weeks or a few months at minimum. A tracheostomy tube being placed needs to be in the conversation or to be considered. It actually does carry some added benefits over the orotracheal intubation. Now, I'll probably mention some that are here, some that are not even here, but it eliminates vocal cord injury. The endotracheal tube going past the vocal cords, as that endotracheal tube has the potential to move and slide, it's rubbing against the vocal cords, rubbing against the vocal cords. Some things we'll talk about toward the end of this today, additional damage that can occur with the vocal cords or at that level. Increased patient comfort. When you think about the endotracheal tube and its diameter, even a properly sized endotracheal tube, and the tube itself is what, something like this long? If I can, again, think of how difficult it would be to breathe through that if it was you. I give you a clean endotracheal tube and say, okay, you can only breathe through the endotracheal tube. Let's go walk up and down the stairwell. It's my straw analogy for asthma all over again, right? For healthy people like you guys, you would get winded only breathing through that straw. It's like if anybody's ever snorkeled and you can only breathe through the snorkel, except this snorkel is not this big around, it's only a quarter of the size of the snorkel. And that's how you're gonna breathe 24/7 around the clock with an endotracheal tube. With a tracheostomy tube, instead of the endotracheal tube that's, say, this long, tracheostomy tube that is this long creates less airway resistance. So may make it easier for the patient actually to breathe. Less need for deep sedation, easier to remove secretions because the tracheostomy is right there already in the trachea. Decreased work of breathing, potential shorter weaning times to get them off the ventilator.
I bet singers do that. If something were to happen, I bet it's in like some directive for them.
I wouldn't know about that.
I mean, if it didn't injure their vocal cords.
Right, but there's other things that are involved there. It can lead to scarring. Tracheostomy tubes. Sometimes you see people that had tracheostomy tubes years and years ago. You may still see the scar. I mean, that's an unfortunate thing that happens, but rather have a scar than not be here, right? And it's not listed here, but the endotracheal tube for someone who's orally intubated over days and days and days, you know what that does to your lip and your skin? It breaks it down. It starts to break down the lip and skin wherever that tube is. It's one of the things, and we'll learn this in time, as a respiratory therapist, when somebody's orally intubated, guess what we have to do from time to time? At least once a shift. We have to move the tube. So it's not rubbing on this spot, now it's going to rub on this spot. And 12 hours later, we're going to put it back here or back in the middle. We're responsible for moving that tube so it's not rubbing on someone's face.
For the length of time, it could like make or like we saw a patient, their tongue was necrotic.
Yeah. From that PVC material type endotracheal tube. And so you get that area necrotic, now they're more prone to infection and all the other stuff.
Okay, is it possible for them not to be able to do a trach on somebody? Because I think that's what we saw when they were in the hospital.
To not do a
Yeah,
trach?
like it wasn't successful, they couldn't do that. Was it
Generally,
tried
trachs are
at a later day, or like?
Generally, trachs are pretty easy for the physician or surgeon to place. I'm not sure of the situation you guys were in that you guys got to see, but again, there's going to be patients that are more challenging, more difficult than others.
I said it was challenging. I can't remember exactly what the specifics were. He was a very large guy, though.
And that's part of it. Size does matter when it comes to how easy it is to get to someone's trachea. I mean, the more mass, the more tissue here. But guess what? They do make special tracheostomy tubes that can go a little bit further than, say, the average adult, average individual. All right, so as far as procedures or how, just getting to some basic stuff here, 2 different types of ways to place a tracheotomy or place a tracheostomy tube. Number 1, traditional surgical method, where they go in, they cut through some layers of tissue, getting in, using instruments to open up and expose eventually the trachea. Okay, once that is, and you can see the tracheal ring, so I know that's the trachea, tracheostomy tube would be placed. Okay, that's one way. That's the typical traditional way, the way it's always been. Not, of course, these cartoon pictures are not the best because it is a pretty bloody type procedure. Okay, this is going to be prone to more potentials for scarring. Then a newer method known as a percutaneous tracheostomy, or you may hear the term a perc trach. Hey, we're doing a perk trach next door. You guys want to come see? Absolutely. It's still a tracheostomy, so it's still going to be a tracheostomy tube. So it's still going to be a hole in someone's neck, but how they do it is a little, for lack of a better word on my part, a little more gentle than all the cutting and slicing and dicing it takes to get to the trachea with the traditional surgical method. They use a needle and a sheath and a guide wire to create a much smaller incision into the neck and into the trachea. They will then use that guide wire and the sheath to sit there, and this blue thing represents the sheath, to push, and it will then, again, the initial hole is fairly small, but it will push, and that sheath will end up dilating the hole here in the neck, that they can then slide that tracheostomy tube down through. They'll remove the guide wire, they'll remove the sheath, leaving nothing but the tracheostomy. So still invasive, still considered a surgical procedure, but it tends to be a little less traumatic, less bleeding, less prone to scarring with the percutaneous method.
Are the tracheal rings like, they're cartilage, right?
Mm-hmm.
So when they do the percutaneous, how many, do they still, obviously
They
they're
still
not
go
cutting.
to about the same spot,
But
between the second and third tracheal ring.
Okay, and they're still cutting those, it's just not as.
Between.
Okay, they're
the
doing
tracheal
between, okay.
rings. Between the tracheal
So they're not
rings.
cutting them then?
No,
Okay.
between the tracheal rings. All right, transitioning here for just a couple of slides, and we'll go back into trachs here. Sorry, trying to stay somewhat following the book here. The term laryngectomy. This is total removal of the larynx. You can think of that as the voice box. Okay, total, complete removal. Seen with patients who have laryngeal cancer. Other reasons, sure, severe trauma, etc., but typical laryngeal cancer. That creates a stoma. A stoma is simply the opening here in the neck, okay? Creating an opening between the trachea and the outside world through this stoma. And so the patient will only be able to breathe in and out through their stoma. Let me jump ahead here and show you the picture. So in this example, here's a laryngectomy. They removed the larynx, leaving a stoma. So here's the trachea. The stoma is the opening here in the neck. Here's the oropharynx, here's the esophagus. Totally 100% separate. Where yours and mine right now, there's both, and then the epiglottis that closes over to protect the trachea, right? When we swallow food, drink water, etc. So there is complete 100% separation between those two pipes now. If you were to sit there and grab a laryngoscope and look in, all you're gonna see is the esophagus, okay? Because the trachea is now open here to the outside, stoma. This next picture, and I'll jump back here, they could perform what they call a TEP procedure, tracheoesophageal puncture. That creates a one-way valve allowing, let me go to the picture here, which will allow air to freely pass between the trachea and the esophagus. So again, esophagus here, trachea here, there's the stoma opening. The TEP is this little connection between the trachea and the esophagus. If the patient was to occlude their stomal opening, and they would have to manually, physically do this, occlude their stomal opening, they would then force air back up through their upper airway. Now, again, what's missing here because of the procedure? Vocal cords. So before you think, oh, they can move air, they can talk again, not so much, not as easy. But they can create vibrations on the wall, so they can make some sounds. They may be able to talk some, but again, it's not because of the vocal cords, because the vocal cords in this example are gone.
Is that what it is from like those cigarette commercials where they like hold their throat and they're like, I've been smoking for 60 years. Is that it? No.
I'm not sure. Can you do it one more time? Sorry.
That's all that I was thinking about just now. But yeah, okay.
Who do you think is the prime patient to develop laryngeal cancer?
Okay.
Obviously, clearly. Whoops. Clearly. But the water might drop. How about that? All right, so sorry about that little brief dip into laryngectomy, but let's go back to tracheostomies or tracheostomy tubes. Okay, that's something you're going to see this Friday. I know everybody's going to be excited about wanting to be able to intubate, which everybody usually is. But this Friday, you're also gonna be exposed to the different types of tracheostomy tubes. So I want you guys to be familiar with them today, so Friday it makes sense what you're handling, what you're looking at. So made from different materials, of polyvinyl chloride or silicone type materials. Some could even be made out of metal.
Sorry, just to go back to the, what we were just talking about, if they're having to manually like cover the stoma, is that not gonna like introduce infection?
Yeah, always possible, of course,
Are
always
they like
possible.
more prone to having like,
Yes.
lower like?
Yes,
infection?
absolutely, absolutely. So yeah, if their hand hygiene is poor and now they're touching their stoma opening, yeah, that's a prime way to introduce germs, microorganisms to their trachea, which could migrate down to the lung, and then, yeah, absolutely.
Alright, my bad.
All right, so parts of a tracheostomy tube. A represents the flange or faceplate. B represents the tube itself. In this example, I'm going to call it the outer cannula. And the reason I call it the outer cannula is because letter C, there's actually an inner cannula inside. But some can only have one. Just depends on the type or style we're working with here. But some can only have one actual tube. A cuff. D represents a cuff. E represents a pilot balloon. Adding air to the pilot balloon can inflate the cuff, but I also will say this, there's some tracheostomy tubes that contain no cuff. And if it has no cuff, it also has no pilot balloon. And then the obturator, the last thing here. Now the obturator, go ahead and jot this down because I don't think I have a spot here that I'll mention it again. The obturator is inserted inside of the tracheostomy tube to be used only during insertion of the tracheostomy tube. So the obturator is only used for insertion during the tracheostomy tube placement. You'll see it, and it'll be better when you have your hands on it and can actually see how it works. But if we had to place a tracheostomy tube, and there's times the respiratory therapist has to remove the tracheostomy tube, clean it, or dispose of it, and replace it with another one. Again, the surgeon, the doc's the one who did all the cutting, but we may be the ones who are replacing the tracheostomy tube from time to time. When we insert it, I don't want to have this kind of rough, jagged end that I'm pushing into the neck and pushing into the trachea. So the obturator is going to be inside of here, creating a more smooth end. So it's easier to place and push that tracheostomy tube into the trachea.
So does it kind of act like the equivalent of a stylet?
I was going to say that, and I'm being cautious. Stylets used for insertion of an endotracheal tube, absolutely. But stylet adds rigidity to the endotracheal tube. This is already rigid enough, right? But it is used just like a stylet only during insertion.
So that's just for like to have not so sharp end going
Correct, correct. You end up with a smoother end here. Just used for insertion, because this thing would take up the space on the inside where you would expect air to go back and forth. So remember that about an obturator, only used for insertion. This, again, example how a tracheostomy tube would kind of function here. This is a cuffed tracheostomy tube. So in this particular picture, the cuff is inflated. The patient will inspire and expire only through the tracheostomy tube. Back and forth through the tracheostomy tube. Because the cuff's inflated, air cannot travel back up through the upper airway. Air cannot travel back up, can't go past the vocal cords, so the patient would not be able to speak, would not be able to make sound, right? Because the air is going back and forth here. And we'll get to that, I know. All right, again, just another example. Now this one includes a plug there in the very far left here, a plug. That plug can be used maybe to block or occlude the outer cannula. But what if I attach that plug to this patient? Guess what they're not going to be able to do? They're not going to be able to breathe. Absolutely not. So there are certain times we're going to use the plug. Obviously this would not be one of them. Might as well just cover their nose and mouth and say, I'm not going to let you breathe. Right? If this tracheostomy tube was plugged. Now we'll get to when we can use a plug here in just a minute.
I don't know how to say it, the obturator?
Obturator.
Obturator. For that, it would go into the inner cannula, right?
The inner cannula would be removed,
Okay.
and it would take its spot.
Oh, okay.
Just during insertion. Again, just during insertion.
So then after you would put the intercannula back?
Right, obturator, once it's properly placed, the obturator removed, intercannula placed back in.
Okay.
And sometimes the reason being for the two cannulas, the outer and the inner, you think they should get some mucus buildup? Yeah, we typically can take out the intercannula, clean it, and place it back, or remove the intercannula, dispose of it, and replace it with a brand new one.
So back to that first slide, A, B, C, D, E, F. F is the obturator, okay?
Yes, that's the obturator.
So you're putting that inside of B, the
Correct.
outer cannula,
Correct, correct.
for the placement?
Yep.
Okay.
Again, just for placement of the tracheostomy tube. Now, again, I'll go over a few different types of tracheostomy tubes. This one, known as a fenestrated tracheostomy tube. This looks just like your standard tracheostomy tube with one addition. A hole that's in the posterior back end of that tracheostomy tube. And so if you think about this hole being in the back end, okay, well that can create some opportunities to do some things. Again, we talked about before, for a traditional trach, air just going back and forth between the tracheostomy tube and the patient's lungs. With an fenestrated tracheostomy tube, if the inner cannula is removed, which would then expose this opening on that outer cannula, and I was to occlude or block this, and I will add one more step, and I deflate the cuff, and I want to create as little resistance as possible, and I deflate the cuff, guess what the patient can do? They can move air through their upper airway, including past their vocal cords, and communicate with us and speak, but they can now move air back through their upper airway with the fenestrated tracheostomy tube. So today, our patient who has one of these, I want them to breathe all on their own, and I could attach a nasal cannula here, because again, they're breathing in back and forth through their upper airway, as long as I know what I'm doing, as long as I'm occluding this. Remember that plug? It'd be the perfect time to put the plug in there so the patient doesn't have to keep holding their tracheostomy tube opening closed. Today, the patient was able to breathe for 6 hours on their own. Oxygen saturation's looking great, their vital signs looking great, they were looking great, they were feeling good for 6 hours. At about the 6 hour mark, they are starting to get tired. I'm noticing their oxygen saturations are starting to fall, their heart rate and respiratory rate are probably going up a little bit, they're feeling a little more distressed. I can put that patient, if they were originally on the ventilator, and I'm just trying to wean them and give them opportunity to be off the ventilator for a little bit. Today it was 6 hours. Guess what I can do for them now through the night, and then tomorrow we can start all over again. I can put them back on the ventilator. How can I put them back on the ventilator? I remove the cap, or remove the plug, excuse me, remove the plug, put the inner cannula back in, inflate the cuff, and now I can connect the patient back to the ventilator. And so tonight, this afternoon, this evening, tonight, I can now rest the patient. Let the ventilator do the work, patient. You rest. You worked hard for 6 hours today, breathing all on your own. Now I want you to rest. Let the ventilator do the work. Tomorrow, guess what we're going to do? We're going to do this all over again. Take you off the ventilator, let you breathe, occlude this, let you breathe through your upper airway, getting used to your respiratory muscles doing some work, and maybe tomorrow we'll shoot for 7 hours or 8 hours. Again, maybe tomorrow I get them 7 hours, and then I have to put it back on the ventilator. The day after, so day 3, now I shoot for 8 hours or 9 hours. See what I'm saying? Just to get them used to breathing on their own. But with this style of tube, I'm not having to take out the entire tracheostomy tube and reinsert it with something different. I could use that same type of tracheostomy tube and go from being off the ventilator to back on the ventilator, all in the same day, within a matter of just a couple minutes from each other. So that's a fenestrated tracheostomy tube. Again, another image of it. Again, this from the back side, the posterior side. You can see that opening in the back. But again, if I'm going to use it for its fenestration purposes to get air back through the upper airway, we must also make sure the cuff is deflated. Now, a speaking valve could be attached. A one-way speaking valve, the term passi mirror PASSY-MUIR, Passymir. Now that's a brand name, but it's probably the most popular brand name of speaking valve that there's out there today. Now how this functions, again, would work great with the patient with the fenestrated tracheostomy tube, because this speaking valve acts as a one-way valve. I can attach it to the patient's tracheostomy tube. Fenestration open, cuff deflated. They could pull air in through, again, path of least resistance, they can pull air in through their tracheostomy tube. But when they exhale, instead of the air coming back out here, this basically blocks it, because it's a one-way valve, and forces air through their upper airway. An additional benefit that we see with this, again, this particular color is not the appropriate one, but there is a different type of speaking valve where the patient can still be attached to the ventilator. So the ventilator is doing the breathing for the patient, air is going through here, inflating the lung, but when the patient exhales, that valve closes, forcing air back to their upper airway. Again, and I use him always as an example for this. The actor Christopher Reeve, who broke his neck in a horse riding accident, I think I mentioned him earlier. He was on a ventilator for the rest of his life. Until the day he died, he was on a ventilator. But if you heard him speak publicly, he still talked. The reason? He had one of these. He had one of these speaking valves. The ventilator still gave him a breath, but once the breath was in his lung, when he would exhale, the valve would close and allow him to move air back to the upper airway. And so he was able to speak. And it's a wonderful thing to be a part of when you're the respiratory therapist and you're adding for the first time a speaking valve for this patient. And again, it might not be left in for very long. Could be today we're going to try 10 minutes, tomorrow 20 minutes, and we'll build up. Or we even go in there with speech therapy to perform this. But it's really, at least myself personally, it's very rewarding when you put this on a patient. Because again, a patient on a ventilator, even if they're alert and awake, they can't talk, right? They can't talk. Their loved ones are at their bedside, they're holding their hand, the visitors, the loved ones are telling the patient things, of course, but the patient can't say anything. You know, maybe they can write a note or gesture, whatever, but you can't speak. But it's great as a respiratory therapist, we're in the room and we put this on the patient for the very first time. And the patient tells their loved ones, I love you, or, you know, good to see you, or thank you for coming. I mean, it's one of the things I gotta toughen up, turn around for a second until I don't cry in the room, right? Yeah, somebody's cutting onions, I'm sure. But it's really amazing. It's really cool to be a part of.
And so
like I said,
so they inhale air through that, and when they speak, it's through that. But
so
then
during
exhale
inhalation, it opens. They can pull air in. When they exhale, it closes because again, it's a one-way valve.
Yeah.
It closes, so instead of air going out through the neck, it goes back up through the upper airway. Past the vocal cords, back out the mouth.
Gotcha. Okay.
I couldn't, in this example, I couldn't say, well, I could put them on a nasal cannula now, because no, they're not breathing in through this way. They're still breathing in through their tracheostomy.
So could you put like one of those trach collars on and put oxygen through that with that valve on, or we gotta take it off?
You could. You could. All right, looking at the front flange, that's what we're going to see, because obviously the tracheostomy tube is going to be inside the neck, inside the trachea. We can't see it. So some things on the outside. Tracheostomy size. Now this is a manufacturer number, but you can even see the internal diameter and the outer diameter, just like we do with an endotracheal tube. Inner diameter, outer diameter. Now this says inner diameter is a 7.6. Millimeter, 7.6. It's the manufacturer that says this is our version of an 8. Now the next company may have a 7.8 and they call theirs an 8. Again, rounding up. And so don't always get hung up on, oh, that must be 8 millimeter. No, technically it's a 7.6. All right, but they call it 8. DCT, disposable intercannula trach. Nothing else other than a manufacturing number. On this one, notice it says there is no cuff. Because remember, you can't see the cuff on the inside. It's in someone's neck, inside someone's trachea. But by looking at the flange, you can see, oh, their tracheostomy tube has no cuff. Guess what this patient cannot be placed on? A ventilator. Alright, because for it to be placed on a ventilator, you have to have a cuff to seal itself in the trachea.
Mhm.
So in this example, this would not be a appropriate type tube for a mechanically ventilated patient. It's a size manufacturer size 6, but it's really a 6.4 internal diameter and outside diameter of 10.8. Cuffless fenestrated tracheostomy tube. I didn't
So-
make up these initials. It's from the
So
manufacturer.
the cup is those two, the clamp on the side of the side on there. On the left one?
Is what's the cuff?
That's the cup, the pieces right there?
The cuff's gonna be down here somewhere. Remember what the cuff?
Oh,
there
okay,
at the
okay,
end?
yeah, okay, never
What
mind.
you will find on this one, maybe just another clue, is you will see it has to have a pilot
Okay.
balloon. This one, I know it's hard to see it, we don't have it in front of us. You would not see a pilot balloon, because
Okay.
again, there's no cuff.
So
But
what
you'll see examples of these on Friday. So,
What would you use the no cuff for, like,
patient needs a tracheostomy. I'm sorry, this is may come across as being a silly answer, but a patient who needs the tracheostomy for whatever reason, but they do not need mechanical ventilation. Okay, maybe it's they've had such a buildup of secretions. We're having to suction them so often, and I still mean twice today or 4 times, no, so often that they're gonna drown in secretions if we can't get a better handle on it. Maybe they put a tracheostomy tube like this. The patient's strong enough and
Okay.
healthy enough to breathe on their own. For whatever reason, it's just these buildup of secretion issues. Just as one example.
Okay. So you would go by the trach size no matter what, right? And then like the inner is like just to know, I guess.
Just to
the
know
gauges.
specifics,
Okay.
right, to know specifics. And this, because this again is just one manufacturer's 8 and 6. Let's see, what else do I have here? Oh, just a few examples of some other, and there's even more than this. I just wanted to give you a few examples. Not every single tracheostomy tube looks exactly the same. Again, you can see this one here's, again, it's hard to see it here, but no cuff, clearly no cuff, no pilot balloon. These are kind of special sized tracheostomy tube. Makes me think of your big guy at the hospital, you know, who had a lot more girth maybe here in the neck. So his tracheostomy tube probably needed to be a little bit longer this direction, just because of the size of the neck. Now something like this, maybe the tube and the trachea needs to be a little bit longer. Maybe there's something restricting here, like a tumor or something. So again, different sizes, some that go a little further this direction, some that may go a little further that direction. Again, just for the type of patient or situation we're dealing with.
So, like, for the endotracheal tube, there's concerns about, like, skin breakdown around the lips. Are there concerns for skin breakdown?
Without
around
proper
the trach?
care, right, and tracheostomy care is not something we're gonna talk about today or even with this chapter, but that's a whole nother avenue of, okay, how do we care for the patient who has a tracheostomy tube? Because it does have to be cleaned routinely. If not, they're more prone to develop infections, and again, there's a open source to get from out here to inside the body. So yes, absolutely, there's still concern for infection. Oh, the one on the far right, I just added, I think we have one of these in the lab. This is known as a Bavona foam cuff. Foam cuff. So the cuff itself is made out of foam that I don't necessarily add air to it, but this foam, almost spongy-like material, has a pilot balloon line that I would have to remove air from it, and that would cause this to shrink, to be inserted. And when I'm done, I don't have to add air back. I simply expose this to the atmosphere, and it will inflate. Supposedly, purpose here, it creates less trauma on the tracheal wall as opposed to a regular cuff that's filled with air. I'm waiting for the day that endotracheal tubes may have a style like this. And maybe they're out there, maybe they're too expensive, I've never seen one.
It doesn't like absorb anything because it's foam?
No, it's inside the cuff is
okay.
foam. The outside is still the same material as any traditional cuff.
It's just like the rational for the mattress, right, that adapts to the anatomy.
Yes, yeah, right. So it kind of just fills that space that's there. All right, this is a metal one. Jackson tracheostomy tube is what it's called, but a stainless steel tube. Generally long-term usage here. Again, the stainless steel tends to last a lot longer than some of the other materials. But notice, no cuff would not be appropriate for a mechanically ventilated patient. So if this is the tracheostomy tube, the Jackson metal tracheostomy tube, what do you think this is? The inner cannula. That would slide right inside. And what do you think this thing is? The obturator, right? So even for these metal tracheostomy tubes, the parts and pieces can still be there. All right, some other things, surgical emergency airways beyond the tracheostomy. All right, so used in emergent situations, like what we talked about already is an emergency. But emergent situations where we cannot intubate, cannot ventilate the patient. Cannot intubate for whatever reason, can't even ventilate them, so even using the bag valve mask system, that is not working. Again, an emergent surgical tracheal airway would need to be established. The term cricothyrotomy, that's a surgical incision through the cricoid cartilage. On the outside, it looks very similar to how a trach would look, but they are, and again, it's not us, it's the physician, or better yet, the surgeon who's doing a surgical incision on the cricothyroid membrane and allows an opening there for us to be able to still now ventilate and oxygenate a patient. Percutaneous transtracheal ventilation, very similar, but these are special surgical emergent airways for patients we can't intubate, we can't ventilate, but we need to get some air in their lungs, obviously. All right, so some airway trauma seen with tracheal tubes, whether it's an endotracheal tube or tracheostomy tube. Anytime we allow pressure to occur on the soft tissues, it can lead to ischemia and ulceration. So if you think about where these tubes are placed, where they potentially could be rubbing up against, or where we allow pressure to be forced on a location, again, could lead to, and ischemia is a fancy word for lack of oxygen. So lack of oxygen going to a tissue. You know, if we apply so much pressure, so let's assume this is a tracheal wall or a vocal cord or something, if the pressure is allowed to, I don't know if there's a class next door, but if the pressure is allowed to do something like this, what's underneath our skin? Capillaries, there's blood flow that's carrying oxygen to supply our tissues. If I'm blocking, could I be pushing and blocking some capillaries, some blood flow? That's what leads to ischemia or eventual ulceration.
I have a question.
Yes?
If you try to talk with an AET tube in, it's just like your vocal cords are like, aren't they trying to like rub?
Yeah.
So like
Sure.
that's what
Sure.
causes
Or cough.
that.
You know, vocal cords, when you cough, are going to close around, and if the patient's oral tracheally intubated with the ET tube, yeah, they're still coughing, but around the tube. Right? There could be lesions in the larynx, so laryngeal lesions. Most common that we see are glottic edema. What's edema? Swelling. So swelling there within the glottis. Vocal cord inflammation, laryngeal or vocal cord ulcerations, polyps or granulomas. Look at this person's poor vocal cords. I'm not saying this is exactly from an endotracheal tube, but it wouldn't surprise me if the tube was rubbing up against this particular vocal cord. You know, patients can move their tubes, even though we have the tube cuff inflated, we have a very good secure tape job. If the patient moves their neck back and forth, that tube can slide back and forth in their trachea, maybe rub back and forth here on the vocal cord. Patient may have hoarseness or stridor. You and I haven't talked about stridor yet, have we? No. All right, stridor is a breath sound you hear from when the airway diameter gets extremely small. It makes kind of a whistling sound. It sounds similar to what a wheeze sounds like, high pitched, except it's occurring in the upper airway, not the distal airway like we see with an asthmatic who's wheezing. So hearing stridor on a patient, that gives me pause and concern that is their airway closing shut? Because I'm hearing stridor when there's some air, but it's sliding through a very narrowed airway. We'll talk about that more in the coming weeks, I want to say, in the patient assessment class on Tuesdays. But with glottic edema, of these, that's probably the most common one. That's swelling here in the glottis. But watch for swelling of the airway to worsen over the perhaps 24 hours after a patient's been extubated. Once the tube's been removed, think everything's great, good. They don't need the ventilator anymore, they don't need the breathing tube anymore, but for the next 24 hours, we're gonna make sure there's no additional swelling, because if swelling's gonna occur, it's gonna occur after the tube's been removed. There could be lesions within the trachea. So here's the trachea. You can see the tracheal rings here. Granulomas, tracheal stenosis, which is a narrowing of the trachea. A tracheoesophageal fistula, TE fistula for short. There's one. So that means, think about where the trachea is. So for myself, the trachea is here in front, and what's right behind it? The esophagus. If somehow I'm allowing that tube or cuff or pressure to create a hole between these two pipes, now I have the esophagus and the trachea connected. So anything in the esophagus could come up and go through that hole and end up where? In the trachea.
Now, if swelling did occur, would it close like up, so that way they couldn't breathe? Would you
Worst case scenario, yes.
And you would have to re-put it back in, right?
Before it closes up,
Yeah.
yeah, absolutely. This last one here, tracheoinaument artery fistula. There's an artery that goes really close through here. Again, very rare, but potential. If it creates an opening between that artery and the trachea, guess what the patient's going to be bringing up out of their trachea? Blood. Bright, fresh, red, frank blood. Again, a lot of these are very rare, but I'll tell you there's ways we can prevent these things from happening. All right, so tube movement, primary cause of injury here. Again, you can see in my pictures here, patient kind of flexing or extending their neck, and if you kind of follow where the tube is, and let's just say where the cuff is, you can see how the whole tube and cuff can move based on the patient flexing or extending their neck. So how can we keep the patient from doing that? Maybe sedation, even though we are being very cautious when we talk about sedation. We just don't want to knock somebody out just because. But maybe having them under a little bit better sedation control may not allow them to move so freely or as much. Nasotracheal tubes are easier to stabilize, so maybe there's an added perk for the nasotracheal intubation. Correct selection of correct airway size is important, but don't change the ET tube unless it's absolutely necessary. Remember I said before, we need to know what a normal tracheostomy tube size is for an adult female and an adult male, right? Some numbers that are associated with that, right? When there's 7.5 or there's an 8, those sort of things. What if the patient was intubated with a tube that was a little too big or a little too small? Again, that's what I mean by here. We won't switch it out unless it's absolutely necessary, because at the very least, we have an airway in right now. The other thing, the cuff and how much air we add to the cuff. There's folks out there that are very poor or bad when they decide to add air to the cuff. They add air to the cuff with no checks or verifications that what you added was appropriate or was enough. They simply just grab a syringe and add air to the cuff. Now, using this wall as an analogy again, if this is the tracheal or mucosal wall, and again, the cuff fills the space, okay, so there has to be another wall on the side, right? So the cuff fills the space, that keeps air going back and forth through the tube. If I don't add enough air, however, what's going to happen? Air is going to leak around, and so it doesn't create a good seal. But if I add too much air, I'm pushing really hard on this wall, too much air, what could it do to blood flow? It can occlude or block blood flow. So there's a very fine line. I want to make sure I add enough air, but not too little, where now there's air going to leak around the underinflated cuff, or not too much, where I could block or occlude tracheal blood flow, or mucosal blood flow. So, again, kind of fine line there between both of them. So, if I add air to the cuff, okay, if I add air to the cuff, please make sure that not only that I have to add air to the cuff for whatever reason, but you check what the cuff pressure is. There's folks that'll just add air to the cuff and just be blind to, I don't know how much pressure that was, because they never check it. In some hospitals, and I believe in most, if not, I don't want to say all, because I don't know for a fact, but I believe most, if not all hospitals, require the respiratory therapist, because we're managing these tubes, to document what the cuff pressure is. Sometimes it could be every time we check on the patient, sometimes it could be at a certain scheduled interval, 4 hours, 6 hours, 12 hours, whatever the case may be. But somewhere there should be documentation that that cuff pressure was somewhere between 20 and 30 centimeters of water. Anything in excess of 30, we know can occlude or block tracheal blood flow, which could lead to problems. Anything under 20, we know could allow air to leak back up and around the underinflated cuff. Again, if you're curious how you can check it, you simply attach it to the pilot line. It's very simple. You can attach it to the pilot line, and you can see what the pressure is. Now, these things are nice. These things are nice because if you needed to add a little bit of air, it's like a blood pressure cuff. You squeeze this piece, and guess what it'll do? It'll add more air to the cuff. If you realize, oh, that was too much, there's a little button on the back, a little trigger on the back that you can press and release, and it'll release some air from the cuff. So these are very nice. This prevents me from even needing a syringe anymore. I can simply add that, squeeze it, add a little bit more air, I will see more pressure, or I can release the trigger button on the back and release some air and see the pressure go down.
How would that work with like the foam?
Foam's different. Foam's different because it's not true. It's not air. It's foam that's inflated. It's not air. All right. So these only work with air-filled cuffs. We'll get to a time later. Silicone gets added to this, but generally speaking, air-filled cuffs. Checking that pressure. We're even to the point today that some mechanical ventilators can be attached to the pilot line, and now I no longer even need this. Through the software of the ventilator, I could add air, I could release air, and I can get a constant 24/7 measurement of what the cuff pressure is.
I thought he was about to say that it was like, that being hooked up like that, it would be auto, and it would automatically inflate or deflate based on pressure.
I'm not sure about auto inflate or deflate, but it will auto let me know what the
No,
pressure
yeah.
is.
I just thought you were about to say that. I was gonna be like, holy shit, but.
No, not replacing us completely. Technology is great, but I can't get rid of us completely. But now there's no excuse why somebody says, well, I didn't know what, I was just adding air to the cuff. I didn't know what the pressure was. No. And I can't say every single ventilator does that. There's some that do, and that's a newer thing, where those that can't do it. And we'll talk about high pressure, low pressure cuffs here on the next one on Wednesday. But I wanted to share this. I think this is my last slide. Yes? No? Yes? All right. High pressure cuffs. Again, adding air to the cuff and exceeding that 30 centimeters of water can cause tracheal wall damage. Left in position at that high elevated pressure for long periods of time can cause necrosis of the tracheal mucosa. See where it's all dead and black? Where do you, this is a trachea. That's where the cuff was. Overinflated for days, weeks at a time. Obviously the patient didn't survive, and they may have passed for other reasons, not necessarily because of too much pressure on the cuff, but this is what their trachea looked like. And that's where the cuff was. Again, I always share this slide when we talk about cuff pressures because it's important. It's important. I know we would never do this intentionally to a patient, but if I just simply blindly add air to someone's cuff and never check and verify the pressure, who's to say I added air, you added air, the patient's nurse added air, the doc was in the room and decided to add some air, and nobody knew about the other adding air to that cuff, and no one checked the pressure, could we be causing this? All right, questions?
Yeah, I've got a question. So when do we, is it like after intubating? Like, like when do we basically measure the cuff?
As soon as we can,
Okay.
actually. Now, if we're intubating, my number one concern at that moment in time is getting the tube in the right spot, and getting it sealed and trained. You probably will see me grab that syringe, add air. Like, John, did you check? No, we need this guy needs his airway. Once everything settles down, and now we attach to the ventilator, he's stabilizing. Okay, let's see what the cuff pressure is. You know, that'll be part of probably our initial documentation of this whole event, including now that they are on the ventilator, and documenting all the information we're going to get from the ventilator and the patient now. So, but initially, yeah, I'm not overly concerned about, oh, I can't put too much pressure. No, my concern is this guy needs air. This guy needs to be able to breathe. So that's probably the first thing I'm gonna be concerned with. It's after everything settles down, and then we'll start checking pressure. But from that point forward, we should be checking pressure all the time to make sure we're not causing this. All right, a few questions for you guys. I think I asked several today, because I knew I was gonna run out of time like I have right now. Okay, there's 5 questions, not too bad. And we're not that far over time anyways. What's another 20 minutes when you're having fun? When attempting to intubate a patient, what should be the maximum time allowed for each intubation attempt? Is that, and I'll blur it out, is that 10 seconds, 15 seconds, 30 seconds, 60 seconds, or there's no maximum time limit as long as the patient maintains their oxygen saturation? Because that's what we see a lot of times. Right? What's their sat? 97. It's okay? Doc, it's 2.5 minutes. What is it? 95. That's fine. You're still going. It's not how it's supposed to be.
So our lunch.
So what's the answer? C? C, okay. Not to be confused with the 15 seconds that we talked about last week with suction. All right, next, so everybody okay? This one's C, 30 seconds. Next question. Which piece of equipment is generally not necessary for an orotracheal intubation? Is that a laryngoscope? Is that an ET tube, stylet, McGill forceps, syringe, or stethoscope?
D.
For orotracheal intubation. McGill forceps. McGill forceps. Because that's only necessary for a nasotracheal intubation. But the others are necessary for an orotracheal intubation. I didn't say this. Do you need a stylet for a nasotracheal? You do not. You do not. Again, you're going through the nose. It doesn't have to be. You want it to be a little bit more pliable, a little more flexible as it tries to find its way down, and not rigid.
Say that again? I didn't hear it.
Stylet for a nasotracheal intubation.
Oh, okay.
You would not need. Orotracheal, yes. Not for a nasotracheal. At that point, you want it to have some ability to be pliable and move into position. But the answer to this question was D, McGill forceps. Excuse me. Next question. During intubation, how far above the carina should the tip of the ET tube be placed? Is that A, 1 to 2 centimeters, B, 3 to 4 inches, C, 3 to 5 centimeters, D, 5 to 10 inches, or E, 20 to 30 centimeters? C? Sure? It's not B? B doesn't look kind of good? No? Alright, it is C, 3 to 5 inches. But we're doing this all together, so that's great. But you know on the test, when it's just you, and you're looking for familiar numbers, and I mess you up by putting inches as opposed to what was the units? Was centimeters, so don't let me fool you. You're not put 3 to 5 inches, and maybe I should have put 3 to 5 inches and have you sucker you in to pick that one. That is a lot more than 3 to 5 centimeters, right? That's nearly 10 inches, 7 to 10 inches. That 3 to, or yes, that depth, or centimeters, excuse me, sorry. Getting myself all tongue-tied. All right, yeah, so that's around 7 to 10 centimeters just by comparison, so much further. All right, so this one we said was C. This one was C. Next question, what's the name of the laryngoscope blade that is straight? Is that McDonald? Is that McIntosh? Is that Myers? Is it Miller? Is it Mueller? Or my personal favorite, Larry? Hand me the Larry. Larry the lobster. Alright, so this is the Miller. This is the Miller. Have you created an analogy already? The L's in Miller are straight. The C in McIntosh is curved. I don't know if that helps or hurts, but that's an easy way to remember when you think about the words. Miller, the L's, straight. That's why I also gave you Mueller, just to, oh crap, which one is it? But McIntosh, the C in McIntosh, think of it, C being curved. The McIntosh is the curved blade. And I'll come up with something else creative on the test, and it won't be Larry. All right, so this one, the straight blade is Miller. And what is the appropriate cuff pressure that must be maintained with endotracheal tube or tracheostomy tubes? Is that 10 to 20, 20 to 30, 30 to 40, or 40 to 50 centimeters of water? 20 to 30 centimeters of water, or B. This one is B. Questions? It's a lot of information. Absolutely true. It is a lot of information. That's why we're gonna practice a lot of this stuff and see a lot of this stuff on Friday. All right, so I have 11:35 right now. So why don't we go ahead and take a break. We will start back at 12:10. So I'll give you 35 minutes of a break. So 12:10, we'll start back.
It's the Apple one. I bought tips.
Different tips.
Yeah. And I dropped it yesterday, literally, on my kitchen floor.
Yeah.
And so now it's,
You bought them separately.
yeah, I bought it. It's like $10 for the
Okay.
So anyway, it got chipped or whatever, so now it's like scraping on my, thank God I got a cover, but I'm gonna have to replace it and get put a different one on it. But yeah, they're like $9, so I'm just gonna order another set. It comes with 5 tips, but this is the one I like.
Yeah, I like this one, but like I was looking at yours.
I don't like that one
more
because
like
it's
a
too thick.
Yeah. I feel like I'm like
And I like,
tapping my
I like fine tuning
Yeah.
everything I write with.
All that, they're